recorded presentation of the Mario Martinez from Spain, preliminary experience with contour device.
Hello, everyone. It's a pleasure to be here today with another ICENS meeting. First, I would like to thank Dr. Kiron for the invitation and for the allowing to me to participate in this fantastic meeting. I hope that for the next year I could go there physically. Okay, so this talk is about the preliminary experience with the control device. This device belongs to the new group of intrasaccular devices. As you know, there are different possibilities. We have the Medina coil, we have the Luna, the Artis, we have the Web for sure. So at the end, there's a new group of endovascular devices to treat intracranial aneurysms. So the experience that we have with previous devices is we know that we need to cover very well the neck. If we don't cover the neck, even having a good occlusion rate, we are going to have a lot of recanalizations. And we know that from the web experience. So at the end, the main limitation with the web experience is that you need to have a lot of experience to do a proper sizing. It's very complex, to select which device is more appropriate for every single aneurysm. So at the end, you need to be worried about that. Okay, so the contour device has recently saw the preliminary results of the series study. In this group of aneurysm, the results were really, really good, and the device were really safe and effective. So what is the contour device? So the contour device is a nitinol device just designed for covering the neck. It is made by 72 wires. That means that the effect is 144 wires, and that means that it's 3 times more than the regular flow diverter. So the device have different type of configuration depending of the size of the aneurysm. So theoretically, where the device is unconstrained, the device is flat, completely flat. But if you once you place it into the aneurysm, you see that the shape will be this type of cup-like configuration. And with this shape, by covering the neck and having some small protrusion into the parent artery, we can achieve a better occlusion rate by comparing with other disruptors. So at the end, there are different possibilities. You have a device about 5 millimeters, 7, 9, 11, and now we do have one more for 14 millimeters. And it's very easy to select which device is the best in this case. This is the chart provided by the company, and you only need to know the aneurysm neck and the aneurysm width. And based on that, you may select the device very easily. As you see here, we normally oversize a little bit the device to have more protrusion. So for having aneurysms between 3 and 5, for example, millimeters of the neck, we will select the 7 millimeters to have the effect of protrusion into the neck. So technically, it's very easy. You need to measure the neck and the equatorial plane. Again, this is the different type of devices. If you select, for example, with a 5 millimeters neck, you select a 5 millimeters device, the configuration will be too flat, and you don't have enough anchoring force here, and there is more risk of having device protrusion into the aneurysm. So the appropriate device will be for a 5 millimeters neck, place a 7 millimeter device. And you, with this oversize, you will have more anchor of the device in the lateral portions of the aneurysm, and you will have the effect of protrusion into the parent artery a little bit, just to having the flow diversion effect. Okay, so technically, again, you need to be sure the device goes directly into the middle of the aneurysm. It is recommended to have in this straight configuration. Once you are there, you push a little bit the device and very gently unshift the device before fully opening. And the device opens really, really well in every single case. The problem is that if you have, for example, these angulations of the artery, that happens a lot. If you place here the device, you will have this type of problems of compromise of this parent artery. So this is the main limitations of this device when you have this type of configuration of the aneurysms. You may preshape the microcatheter, but even in those situations will be not effective. Okay, so what are the potential indications of the contour device? In my opinion, are wide neck bifurcation aneurysms, cases that you think that are suitable for flow diverter, but the patient cannot receive antiplatelets, so this is a potential options. And well, there are different options, at the end for that. So the preliminary experience we have right now around 30 cases performed, but these analyses are based on the first subgroup of cases. Let me show you the results. So at the end, we treat 7 rupture aneurysms. In those cases, we don't have any rebleeding, we didn't have any thromboembolic events, and it's very important to mention that we use the radial approach in 9 of 15 of the cases. The device pushability was really good and we didn't have any problem. In these preliminary results, we have one gel branch occlusion. This is the only one complications in a case of the MCA bifurcation aneurysm that I will show you right now. Okay, so let's review some cases. These are anterior communicative artery aneurysms with this frontal branch coming from the base of the aneurysm. In this case, we thought about placing a stent or doing a remodeling, but having this small branch, we prefer to protect and place a contour in those situations. So it was a 6.6 millimeters aneurysm with a neck diameter of 3.3 millimeters. So at the end, we select a device of 5. You may see here the frontal branch in the base of the aneurysm. Okay, so let me show you the technique. We select a 7 millimeters device for having a little bit more protrusion, and we navigated in a triaxial system, the Phenom 27. This was the first version of the device. The device right now is compatible with a Phenom 21. Okay, so in this case, we select the Phenom 27 and we open the device very easily. Let me show you how it works, because at the end, what I would like to remind is that it's recommended to use a triaxial system in every single case, because that gives you more stability for the opening of the device. If you don't use intermediate catheter, you may have problem with instability, no stability during the opening. So you see here the device, which is here, the pusher proximal, and the device are navigated into the middle of the aneurysm. So once it's there, you very gently unsheath the microcatheter, unsheath the device. This is the proximal marker that needs to be close to the neck, and once it's there, the device open automatically. So here we are only unsheathing the device. Again, the most recommended microcatheter is the Phenom, which is the most stable for this type of deployments. Okay, and well, this is the final result here. The device fully open at the neck. The artery, proximal artery, is patent, and here is the follow-up with a complete occlusion of the aneurysm. So at the end, it's a very easy way to treat this type of aneurysms. Another anterior communicative artery aneurysms, a little more complex for proximal tortuosity. We did exactly the same technique that placing the microcatheter. Here we have a little more angulation, but anyway, we open the device very easily here. And in this case, is to illustrate that if you push too much, you may have this type of problems. The device is not fully open. So the way to retrieve it is just to open the device and pull everything back to fully open. So the device is open at the dome of the aneurysm here, distally. So once it open, we pull all the microcatheter and the push back, and we adapt to the neck of the aneurysm. This is to illustrate the final opening, and you see here the beautiful stagnation of the aneurysm just immediately after the implant. This is a typical problem that you may have in this situation. For example, this is another anterior communicative artery aneurysm. Here we push too much. You see here the device is bended here. So the way to do that is to retreat back and pull and open more proximally. So it's very similar to the web in terms of deployment, but it's more recommended to open at the level of the neck proximally if you want to avoid this type of device bending on the aneurysm dome. Okay, another case, MCA bifurcation aneurysm, 4.4 millimeters with a small neck. Here you have this frontal branch coming from the base of the aneurysm. You may have different options here, like placing a flow diverter, doing a half T, stenting, whatever. We select the contour device in this case, and based on the neck diameter, the most appropriate one was the 7 millimeter device. So we deployed very easily in 10 minutes or less. So it was super easy to deploy. Let me show you here the deployment. So we push here, and once we have the proximal marker close to the neck, we only unsheath the device here, and let me show you here, and it opens very easy here. Okay. So everything went very good, and this is the 3 months follow-up that we performed, and you see that the aneurysm is completely gone. The artery is completely reconstructed here, is still patent, so this is a nice result of the device. This is the only case that we have a complication, the MCA, right MCA bifurcation aneurysm, with this plastic aneurysm of 9.45 millimeters. We have the superior branch here, which was around 1.2 millimeters. So in these cases, we prefer to avoid a stent in those situations, but well, you have different options to select. So see, this is the measured diameter here. We select a 9 millimeter device based on the neck of the aneurysm. So we opened the device from the beginning. You see very clearly here, the device was fully open, was fully adapted, but we pulled too much and we adapt too much to the artery. You see here that it was the initial deployment here, and we have some small protrusion into the M1. So we wait for some minutes, and we saw the aneurysm was gone here, but the branch was also closed. So at the end, we wait for some time. We saw some collaterals. We extubated to the patient. The patient was non-symptomatic. So when we decide to fully deploy, but you see here is one of the main problems. If you cover these type of branches, having a good collateral, you may have this type of acute occlusion of the branches. And we know that for many years of the flow diverter in bifurcation. So at the end, if you place this type of device into the neck of the MCA bifurcation aneurysms and you cover one branch, you may have something similar of the flow diversion effect. This is the 6-month follow-up with the aneurysm completely reconstructed, and the artery is patent here. Another case, a small case, a right MCA bifurcation aneurysm here. So we select a small contour device. This is the acute, you see the acute occlusion of the aneurysm, which is completely gone, and the artery is fully patent. So at the end, the MCA bifurcation aneurysm is a good option. Okay, this is a nice case to show. It is a rupture case, Kiron aneurysm with a small neck, super easy to treat with a regular calling or with balloon remodeling. But in this case, we need to do it super fast because the patient was very unstable and required to go to the surgery room for an EVD placement and carinectomy decompressive. So at the end, we select the contour device because it was really fast. So we place a 9 millimeters, and you see that right after placing the device, the aneurysm itself was completely gone. So I think it's a potential nice indication of a rupture case. Another rupture case, it was a top basilar rupture subarachnoid hemorrhage with this type of pyramidal configuration here. So in this case, we select a 7 millimeter device and we deployed, but not only on the neck, we deployed even at the dome here for having this complete configuration of the aneurysm for fully covered. This is a different deployment. So with this type of configuration, you may treat this type of aneurysms. Instead, the classical opening, we select for this type of opening for this type of specific pyramidal aneurysms. And you see here that the aneurysm is gone also right after the deployment. Another rupture case, top basilar, wide neck, very complicated to treat endovascularly if you don't want to use a stent. So this is a rupture case. In this case, we select this device, and you see that we have a very nice stagnation. The aneurysm is stabilized. Patient breathes really well. You see this is the contrast stagnation of this complex case, And this we had a 3 months follow-up here. The aneurysm is almost gone. Probably will require a retreatment with flow diverter or with a single stent. But I think for the acute setting, you see here in the left picture, it was the original aneurysms in the acute setting. And right now in the right picture, you have the aneurysms and the 3 months follow-up. So it is not a bad result at all. Another rupture case in a superior cerebral artery aneurysm. We select a 5 mm device. In this case, you see here after deployment, we saw the stagnation and the aneurysm was gone and the parent artery was completely patent. Okay, the device may be work also with combination with coils, so it's another nice case to solve. Right MCA rupture case, bifurcation aneurysms, complex to treat if you want to do it properly. So in this case, what we did is placing a marathon microcatheter gel here on the dome of the aneurysm, and proximally we place the phenom 21. So first we open the device, as you see here in the mid picture, we open the device. You see here very clearly the marathon in a gel fashion here at the dome, and through the marathon we place some barricade coils, and we have proximally the contour device for protect the proximal part of the aneurysm. And this is the final result in the acute setting. You see here the nice embolization results with both parent arteries, with bifurcations, arteries patent. Okay, and another potential use, just to show the versatility of the device, this was a case of a pseudoaneurysm in the common carotid artery after a puncture of a vein puncture. This is the imaging here. You see we did a radial approach, and this is the left common carotid artery, the pseudoaneurysm, and you know the rupture point here. This case have a shock septic, so it couldn't receive and dual antiplatelet therapy and couldn't receive a stent. So in this case, we select the contour device. You see here that we place a balloon distally to allow a proper microcatheterization inside the pseudoaneurysm, and we place the contour just in the point of the rupture here, the perforation. The device fully occlude this rupture, and this is the reconstruction, and you see the complete occlusion, and this is the follow-up with the complete occlusion of the pseudoaneurysm. So this at the end is very versatile, the device you may use in different type of indications. Okay, so in conclusion, the contour device is a very easy device to use. You don't need a really learning curve. It's very easy to size, to select the device. It's a novel concept because it's specifically a neck disruptor. It's not intrasaccular, it's a neck disruptor. You need to be sure that you fully cover the neck and you have a little bit of protrusion. The flow diversion effect is really good. The effect is like 2 or 3 times more than a flow diverter. The best indication is the wide neck bifurcation aneurysm, terminal cases. It's mandatory to use intermediate catheter in every single case, for sure, but you need to study first the perioperative analysis to know the angulation of the artery in order to predict how it's going to be the opening. And for sure, we need more long-term follow-up to really know what is the real occlusion rate, and if we have recanalization of not. And regarding the rupture aneurysm, there are different trials ongoing, so I'm pretty sure that we will have a lot of information in the next future. So thank you very much again, and it's my pleasure to be here. And if you have any questions, please just let me know, and we'll be very happy to discuss with you. Thank you, and have a nice day.